Good morning, everyone. My name is Kate Crump from Health-Centric Advisors, the New England QIN-QIO, and I will be your moderator. Thank you for joining our webinar, Quality Payment Program and Physician Burnout, How to Keep Calm and Report On. Before we get started, I'd like to go over a few housekeeping items. This webinar will be recorded for training purposes. The phone lines have been muted for the duration of the presentation. We will take questions at the end of the presentation. I will provide you instructions on how you can ask a question over the phone at that time. We encourage active participation, so please don't hesitate to post a question in the chat box at any time. Please make sure to send content questions to everyone so our team can assist with monitoring chat. If you're having technical difficulties, please message me, Kate Crump, for assistance, and I'll do my best to help. At the conclusion of the webinar, I'll provide you an evaluation link in the chat box. This link will also be emailed for those of you who are on the phone or sharing a screen. Please let us know how we're doing. Today, we have two presenters from our Health-Centric Advisors Quality Payment Program eligible clinicians team. Susan Whitaker, CPC and CMA, Senior Program Coordinator in Maine, and Tashara James, MA and MHA, Program Coordinator in Massachusetts. Now I'd like to hand it over to Susan. Susan?
Thank you, Kate. Hello, everyone, and thank you for joining. The first thing I wanted to do is talk about our objectives. And Kate, I'm sorry, but I am having trouble advancing the slides.
No worries, you can just tell me and I'll advance for you.
Okay. All right, so let's go to the objectives. Our objectives are to define physician burnout. We'll share some data and studies on burnout. We'll discuss adverse effects of burnout on physicians' performance and the quality payment program score. We'll learn common drivers of burnout, and we'll talk about QPP and financial impact. We'll discuss strategies to overcome QPP reporting-related stress and general strategies to address physician stress. And we'll provide you with some resources and links. Please take a look at our disclaimer on the next slide. And then we'll go to the next slide, please. First of all, let's define burnout. According to the Agency for Healthcare Research and Quality, burnout is a long-term stress reaction marked by emotional exhaustion, depersonalization, and a lack of sense of personal accomplishment. In the Annual Review of Psychology, job burnout was described as a psychological syndrome in response to chronic interpersonal stresses on the job. The three key dimensions of this response are an overwhelming exhaustion, feelings of cynicism and detachment from the job, and a sense of ineffectiveness and lack of accomplishment. In 2018, Medscape reported that 42% of physicians said they were burned out. 12% reported depression, and 3% were actually clinically depressed. Also in 2018, the Journal of the American Medical Association published an article in which they asked the question, do rates of burnout and career choice regret among resident physicians vary by clinical specialty? In this prospective cohort study of 3,588 second-year resident physicians with follow-up since medical school, they reported symptoms of burnout occurring in 45.2% of the participants and career choice regret in 14.1%. However, there were wide ranges of prevalence of burnout by clinical specialty. On the next slide, we take a look at two more studies that show burnout rates among physicians at right about half. In 2012, family physician burnout was rather high at 63%. On the next slide, we'll take a look at currently which physicians are the most burned out. This study from 2019 shows family physicians at a 47% burnout rate, which does seem to be an improvement since the 2012 study. Critical care physicians report the most burnout at 48% and plastic surgery the lowest at 23%. However, if you exclude the plastic surgery results, roughly a third to half of physicians responding to this study report burnout. In this study, researchers surveyed 422 primary care doctors in ambulatory care clinics. Work conditions such as time pressure, chaotic environment, or unfavorable organizational culture, low control over work pace, EHR functionality, and family responsibilities, such as trying to be two places at once, were all strongly associated with physicians' feelings of dissatisfaction, stress, burnout, and intent to leave the practice. Interestingly enough, however, physicians' reactions to these work conditions were not consistently associated with a reduction of quality patient care in this study. The investigators' interpretation was that although physicians are affected by work conditions, their reactions do not translate into poor quality of care in many cases because the physicians act as buffers between the work environment and the patients. What they found was that physician-friendly and family-friendly organizational settings seem to result in greater physician well-being. On this next slide, we're highlighting some general causes of work-related stress, some that we've just talked about: inefficient processes, excessive workloads, work-home conflicts, lack of support, less control, and sometimes just the nature of the job. On the next slide, we'll look at sort of general organizational climate factors like negative leadership behaviors, less collaboration, opportunities for advancement, and lack of social support. And then there are individual factors that also lead to physician burnout: educational debt, for example, lack of work-life balance, and then just personal characteristics. Now let's talk about Medicare's quality payment program and how that contributes to clinician burnout. The quality payment program has two tracks for reporting quality data. In the first track, the MIPS non-ACO track, a clinician or group reports 3 or 4 of the categories themselves. So they would report on the quality category, improvement activities, and promoting interoperability, which is all about EHR functionality. The fourth MIPS category is cost, and Medicare calculates that for you. There's no need to submit any data beyond your claims to Medicare. But MIPS is a complex program. It has a big learning curve and does require extra work and staff time. Also, poor MIPS performance carries a penalty in the form of negative payment adjustments off Medicare Part B checks. Now, the second track is the MIPS, is the advanced APM. If you are in a MIPS advanced payment model or a Medicare shared savings program, then all the categories are reported for you except by the ACO, except the promoting interoperability category. So that lessens the individual burden on the clinician. The entire APM may earn a shared savings performance bonus, or they might share some downside risk. On the next slide, we take a look at the financial impact for clinicians who are outside of an ACO, who do not, who may or may not meet performance thresholds. You'll notice that the positive payment adjustment for good performance does go up every year, but also if you do not meet the quality reporting thresholds, then the financial impact, the negative payment adjustments also go down each year. So robust reporting leads to positive adjustments and additional adjustments to the Medicare Part B checks, but the program is budget neutral. So the positive payments adjustments aren't as robust as they appear here. So in other words, if in the year 2021, if your reporting wasn't robust enough, you would receive a negative 7%. However, if you reported really well, you may not receive the entire positive 7% adjustment. Okay, on the next slide, these are some of the healthcare system level drivers of burnout for clinicians in QPP. The MIPS requirements and thresholds and eligibility criteria change every year. So once you learn the program, you really do have to stay apprised of all the changes. Resources are released last minute, sometimes even after the program has begun, and the program is really complex. The systems of reward and penalties. Reward and penalty percentages increase annually. However, the reward is sometimes too small to promote an incentive. There's a time lag between performance and payment years, and MIPS scores do follow the NPI. In other words, they follow the clinician if the clinician should change jobs. On the next slide, we'll look at some organization practice level drivers of burnout. There is an administrative burden and paperwork. Sometimes you have to redesign the workflow based on the measures that you've chosen to report for QPP. And then choosing the right measures and the reporting mechanism and associated costs all take some planning. Sometimes you can use a registry or consultants to help you in this. Now, a registry is a third-party vendor that would collect data for you and sometimes submit it to CMS. Other drivers of burnout on the organizational level are lack of user-friendly and efficient EHRs, affordability issues, lack of skilled staff or staff turnover, resistance of staff to embrace change and take on those extra tasks, or fear of losing patients and reputation based on MIPS score. The MIPS scores are being reported on the Physician Compare website, so they are public knowledge. On the next slide, the physician level drivers of burnout include things like amount of time clinicians need to spend on administrative work during the course of their day, and that highlights ER physicians who found that they spent nearly half of their time doing their documentation and their data entry. EHR and regulations can negatively affect the physician-patient relationship, sometimes can hurt efficiency and productivity and damage workflow, according to that Healthcare Drive survey. Also on the physician level, a medical group management study from 2018 noted that the following concerns of the value-based payment model is that physicians are not always sure that the nuances of the doctor-patient relationship are honored within the realm of value-based care, that it might focus too much on population health and not enough on individual health. 61% said that value-based care and reimbursement will have a negative impact on their practice, and 63% said it would hurt their earnings. Also, not seeing enough savings or returns from participating in the ACO model, and we talked about that. More than 4 in 10 physicians surveyed said they wouldn't participate in the ACOs or the APM shared savings types of programs, and 56% said they don't expect to take part in patient-centered medical homes. So how does burnout affect the QPP score? Clinician burnout may lead to poor QPP performance and lower scores, resulting in penalties and financial stress. Burnout may result in low quality of care in some cases, however, not all. We did discuss how investigators discovered that that is not always the case. But the penalty and rate of reimbursement on Medicare checks and the financial burden and stress does affect physicians. And now I will hand the presentation over to Tushara, who will discuss some strategies to overcome this stress and succeed in the quality payment program.
So thank you, Susan. In this section, we will discuss why the successful participation in the quality payment program is important, some common drivers of burnout related to QPP reporting, and key strategies to overcome stress to ensure successful participation. Next slide, please. Quality Payment Program transforms the Medicare physician payment system from one focused on volume to one focused on value. The main goals of the Quality Payment Program are to improve the beneficiary health and clinical outcomes, payments based on the performance, improve the quality of care, to promote the use of healthcare information technology, reduce costs, support small practices, and improve access to care. Next slide. We provide QPP technical assistance and support to practices and eligible clinicians in the New England region. We are well aware of their MIPS-related issues, frustrations, and their struggles. But at the end of the day, we help them. We request them to participate in the program rather than moving away from it. Here is why the successful participation in Quality Payment Program is very important. First of all, QPP offers opportunities for reward for high performers as well as penalties for non-performers. Besides, MACRA is here to stay and won't be going away anytime soon, as it was passed in Congress with broad bipartisan support. And the program requirements have been changing, with minimum threshold score increasing year after year, pushing clinicians to perform better. More than anything, QPP has good intentions, and successful participation can help your organization position well in the long run. And MIPS score and data are made available to the public through the Physician Compare website. And there is a great focus on population health, preventative care, patient safety, and engagement too. Last but not the least, QPP promotes collaboration and collective accountability in general. The 4 performance categories of the Quality Payment Program are quality, promoting interoperability, enrollment activities, and cost. Even more than in previous years, CMS is actively trying to reduce physician burnout and regulatory burden MIPS reporting plays on clinicians. Ultimately, CMS's healthcare goal is to improve patient outcomes and reduce overall costs for the US health system through value-based care. In the next section of the presentation, we will be focusing on each MIPS performance category, how to overcome QPP-related stress and perform better. Let's take a look into the quality performance category. Quality performance category measures healthcare processes, outcomes, and patient experiences. It comprises of 45% of the MIPS final score in 2019. Eligible clinicians must report on at least 6 individual measures, including 1 outcome or high priority measure for a full calendar year. We will be discussing some common hurdles faced by clinicians from successfully participating in the quality performance category and some possible solutions. First one is this: I can't find information on quality measures, reporting requirements, and scoring. This is applicable to all MIPS performance categories, not only just for the quality category. The most authentic source of information regarding QPP reporting requirements, measures, and scoring is the qpp.cms.gov website. And I have shared the link here. There is also a resource library on this website where you can find and download additional QPP-related resources, including fact sheets and webinars. Next frequently asked question is, how do I choose the right quality measures? Here are a few tips. Clinicians and groups can choose to report on a specialty or subspecialty measure set. It will ease the process of going through the list of all quality measures and figuring out the applicable measures for your practice. If you are deciding to go with the specialty measure set, you must submit data on at least 6 measures within that set. If the set contains fewer than 6 measures, the clinician or group should submit all measures in the set. And try to report on measures that are easily reportable and based on activities and improvements you are already doing in your practice. Analyze your workflows, choose the measures that are appropriate to your practice and patient population. Make changes to your workflows to fill in gaps, if any, and to accommodate reported requirements of the chosen measures. Resistant staff and employees are another major cause of burnout among physicians and practices. Change is often unwelcomed and resisted by the employees. Here are a few quick tips to mitigate this issue. Most employees fear that they need to work more hours or will be under so much pressure within the new system. The key here is to make sure that they are given adequate training and support throughout, not only just during the transition period. Please keep an open mind to understand the difficulties and stressful situation they are going through to accommodate the workflow, data tracking, and reporting needs of the program. Appreciate their hard work and value their opinions. Another noteworthy point I would like to make is to ensure that your staff understands the importance and value of participating in the quality payment program, including the negative impact of non-participation. A very common issue we often hear from clinicians is them being so busy with their medical practices and not getting enough time to monitor the progress to make sure that everything is going as planned. Adequate planning plays a very important role in the successful participation of the quality payment program. But not just picking up the measures doesn't guarantee any success. Constant monitoring is also equally important. Most clinicians are so busy with their patients and they often crunch to find enough time to monitor the planned processes. In situations like this, weekly huddles, they can be very short, plays an integral role in keeping everyone in the loop. Make it very structured so that time is well spent. Designated people should report out the updates. Similarly, address any needs and discuss on action items, if any. Proper delegation also lightens the workload as well as encourages collaboration and ensures smooth reporting. In this section, we will focus on the promoting interoperability or PI category, the common drivers of burnout, and some ways to mitigate stress. For 2019, PI category is 25% of the final MIPS score, and organizations and practices must use 2015 edition certified EHR technology. Studies show that this category is the biggest driver of QPP related burnout among clinicians. But with proper planning and guidance, most of these issues can be resolved. I would like to go over through some common issues we hear from physicians related to EHR and PI category in general. Number one is this. Should I need an EHR system to participate in the program? Yes, you need to have a 2015 certified EHR technology by the end of the reporting period to successfully participate in the PI category. But a clinician or group participating in QPP may submit a promoting interoperability hardship exception application, citing one of the following reasons for review and approval. If approved, the PI category weight will be reallocated to the quality performance category, making it worth of 70% of the MIPS score. If you are a MIPS eligible clinician in a small practice or MIPS eligible clinician using decertified EHR technology, you can apply for the PI hardship exemption. Similarly, if you have insufficient internet connectivity, for example, your practice is located in a very remote area or you have constant issues with internet in general, making it almost impossible to utilize your EHR system, you are also eligible to apply for the same. Again, extreme and uncontrollable circumstances, for example, natural calamities like flood, tornadoes, etc., or lack of control over the availability of certified EHR technology are also valid reasons for applying for hardship. If a clinician is identified as special status, he or she will be automatically exempted from submitting data under the PI performance category. These MIPS eligible clinicians do not need to submit a quality payment program PI hardship exemption application. Another common concern among physicians is the lack of financial resources to invest in an EHR system. But there are various options to consider even if you don't have access to an EHR system to participate in the QPP. If you are a solo or small practice, you can apply for PI hardship exception. You can also join a group and report under their TIN who has access to an EHR system. As a group, you will report on the same chosen measures for all categories and receive a single group score. And another option, though we do not recommend it often, is to focus on other three categories and get minimum score to avoid a penalty. So basically, you won't be able to meet the reporting requirements of the PI category without an EHR and receive a 0 as a category score. In such scenarios, you need to focus hard on other categories, especially improvement activities and quality. And we understand that many practices are not in a financial position to invest in an EHR system, but we highly recommend you to conduct a cost-benefit analysis to understand the cost versus benefits before you make the final decision regarding the EHR adoption. Do some research, gather some data, and discuss with your counterparts. Meet and talk with different vendors to know your options, including payment options, before you decide. If your EHR has the direct feature, MIPS data can be submitted directly to the CMS by your vendor. If you do not have an EHR, consider third-party vendors for data submission. How do I know my EHR is QPP ready? What are the features I should be looking for? If you are thinking about investing in an EHR, or if you already have one, you need to make sure that it supports your chosen quality payment program measures. Some of the features you need to look to should include flexible templates to meet each patient's healthcare needs and ability to share the patient records between different clinicians or healthcare settings. Most EHRs can be customized to fit the specialty needs and measures. Always look into such options. Make sure that your EHR is user-friendly to both providers and patients. Having an efficient, easy to sign up, and user-friendly portal is a good example. Cloud-based EHR is another option to consider. Records may be able to be uploaded to the cloud, making them accessible from anywhere that has an internet connection. This makes the data tracking and sharing much easier. And as I talked earlier, having an efficient QPP data submission option through your EHR is also very important. Discuss with your vendor about the direct feature of your EHR. It is too much documentation and work, so stressful. We hear this all the time. Here are a few strategies. Consider using EHR scribes to ease your work. Research ties the use of medical scribes for EHR clinical documentation to improve physician satisfaction and reduce physician burnout. Scribes are responsible for all relevant documentation, which are subsequently reviewed by physicians before attestation and signing. Have a cross-trained staff that can handle intake and documentation. Provide training to the existing staff and consider hiring new staff who are efficient and comfortable with electronic data tracking and recording. And make a habit of documenting encounters in detail without missing necessary fields. It will save so much time and stress in the future. And try to finish off all patient encounters, including documentation at the end of each business day if possible, and route documents appropriately and delegate effectively. This includes timely handling of charts, faxes, lab orders, etc. Choosing an EHR vendor and product wisely is very important. Not only the features offered by EHRs, but also the level of support you receive from your vendor is integral. My certified EHR technology vendor said I have to submit all MIPS data through its product and pay additional fees to submit data for each MIPS performance category. Is this true? No. Various submission options are available to choose from for each MIPS performance category. Costs associated with submission via your certified EHR technology vendor can also vary. So it is very important to ensure you are aware of all costs associated and the submission is both complete and accurate. In this section, we will focus on the improvement activities category or IA category. This category is geared towards increased accountability, patient engagement, and patient safety. It accounts for 15% of the final score in 2019, and there are 118 activities to choose from. The biggest concern of many practices with implementing the improvement activities is the disruption of the workflow, how it will affect the employees as well as the care delivery. But here are some strategies that might help. Be smart to choose the activities based on your current workflows so that there will be minimal disruption. Again, please keep in mind that it is very important to actively engage your team while redesigning processes and workflows. Make sure they feel included and their voices are heard. And more than anything, this performance category is focused on identifying the possible opportunities for improvement within your practice and implement measures and interventions to achieve better outcomes. Implementing improvement activities is a great way to identify areas of improvement. Another recommendation is to perform a SWOT analysis, which is a useful technique for understanding the strengths and weaknesses, opportunities, and threats your organization faces. It can be extremely beneficial for an organization to perform a SWOT analysis to choose the right improvement activities for the quality payment program. Improvement activity category is an attestation only category and highly susceptible to audits. But don't stress out, here is what you can do. CMS has the right to audit you up to 10 years. So make sure that you have detailed documentation available in accessible, safe locations. For example, let's consider the following improvement activity. Implementation of improvements that contribute to more timely communication of test results. Proper documentation can be EHR reports from a certified EHR or medical records demonstrating timely communication of abnormal test results to the patient. With proper documentation and trained staff, you can easily surpass an audit. Tracking and measuring your progress periodically is also crucial. Schedule periodic reporting to check progress. Share results with your staff and document. Change or update processes if necessary. Consider redesigning or implementing new strategies to keep your efforts in the right direction. Again, as we all know, patient feedback or survey is another great tool that can be used to track the effectiveness of the implemented activities. We have recently implemented many new processes within our organization to improve care experience, patient safety, and beneficiary engagement. Are there any preferential scoring, flexibilities, or credit opportunities for this category based on what we are already doing in our practice? Yes, there are some preferential scoring, flexibilities, and credit opportunities for this category. If you are a participant in a recognized or certified patient-centered medical home or comparable specialty practice, you will earn the maximum improvement activity performance category score by attesting to this during the submission period. If you are participating in the CMS study on factors associated with reporting quality measures, you will receive full credit in the performance category. The participants need to submit the application form and successfully meet all the study participation requirements to receive full credits. Again, you will receive double points for each high or medium weighted activity you submit if you are an individual clinician, group, or virtual group who holds any of these special statuses: small practice, non-patient facing, rural or health professional shortage area or HPSA. Next, cost performance category. Cost is an important part of the MIPS program as it measures the resource use and overall Medicare health spending. CMS uses Medicare claims data to calculate the cost measure performance, which means clinicians and groups do not have to submit any data for this performance category. Even though there are no reporting requirements for this category, clinicians are still very stressed out, trying hard to control costs without compromising on the quality of care they provide. Am I required to participate and report for this for MIPS cost category? As I mentioned earlier, CMS abstract from Medicare Parts A and B fee-for-service administrative claims. So MIPS eligible clinicians do not have to perform any additional data collection or reporting. Another common concern among practices is effectively containing their costs due to the nature of the specialty or the patient population they serve. We are a small practice located in an expensive urban setting, and our patient population mostly consists of high-risk people with comorbid conditions. Our costs will be always high, however hard we try. CMS understands the concern of these clinicians and introduced payment standardization in the TPCC MSPB and the 8 episode-based cost measures. CMS realizes that the allowed amounts of Medicare services can vary across geographic areas due to several factors such as regional differences in labor costs and practice expenses and differences in relative price of inputs in local markets where service is provided. Price standardization also removes any Medicare payment differences due to the adjustments for geographic differences in wage levels or policy-driven payment adjustments such as for those for teaching hospitals. Cost calculations are also risk adjusted, so higher costs are expected for complex patients. So maximize this category with specific, thorough ICD-10 diagnosis assignment. Here are a few helpful tips to optimize your costs as well as to attain maximum score in this category. First and mostly, focus on value-based care and treatment strategies. Be proactive and provide preventative care to reduce unnecessary hospitalizations. Follow evidence-based care and best practices and ensure effective and efficient treatment strategies are adhered at each stage of treatment. Again, have an efficient billing department in place, including knowledgeable staff. Check NPPES, National Plan and Provider Enumeration System, to ensure correct National Provider Identifier numbers are listed. Regularly update PCOs with most recent Medicare enrollment information. Check Medicare's Physician Compare website to ensure that you and your clinicians are listed appropriately, as misclassification often leads to inappropriate allocation of patients and wrong calculation of costs in general. So this is what clinicians want: flexible schedules, work-home balance, staff surveys, and more time with patients to help with EHR. On this section of the presentation, we will provide you with some general strategies to overcome QPP-related stress. Of all the changes envisioned as a part of the transformation to improved and more patient-centered care through QPP, perhaps none is more promising and more challenging than the transition to team-based delivery of care. A recent study pointed out that team-based care has a positive impact on physician well-being, clinical outcomes, job satisfaction, as well as lower stress levels and clinical exhaustion. Population health management is another concept that is embedded in the quality payment program. A successful population health management program will give real-time insights to both clinicians and administrators and help them to identify and address care gaps within the patient population. Population health management is the aggregation of the patient data across multiple health information technology resources, the analysis of that data into a single, actionable patient record, and the actions through which care providers can improve both clinical and financial outcomes. I'm including a few tips for successful population health management program. I'm not going through them now, but all the information is included on the slide. Eligible clinicians and practices are often confused and stressed out about the data submission options for quality payment program. We always get so many calls and emails from practices during the data submission window period. I would like to share some quick strategies for successful data submission. CMS does not guarantee that all vendors will be successful. The selection of the right submission mechanism for your practice is your responsibility. CMS just gives various options to choose from. Make sure that you choose a vendor from the CMS list of approved qualified clinical data registries or QCDRs and qualified registries. And keep in mind that your certified EHR technology must meet 2015 edition functionality criteria by the Office of National Controller, ONC, certifying that they can submit data to CMS in the appropriate format. And my colleague Radhika will be putting the link in the chat soon. And always reach out to your vendors in advance and determine if they have had reporting issues in the past and how they have resolved these issues going forward. Please don't wait until the very end. And know the various reporting options available to you. Login and attest, login and upload, and Medicare Part B claims only for small practices are the affordable or no cost options. And more than anything, keep an open mind. An open mind to embrace new changes and positive outlook will help you overcome the hurdles along the way. QPP is created with good intentions, and data shows that value-based payment programs will bring down costs and improve the quality of care in the long run. So we request all of you to participate in the program, not just to avoid a penalty, but try your best to become an exceptional performer. Similarly, don't close out yourself to technology. Health information technology, including EHR systems, have positive impact on the quality of care and outcomes when used appropriately. We understand that EHR systems can be confusing and time-consuming. Please keep in mind the strategies I have mentioned earlier to alleviate the stress related to PI category. And sometimes it's okay to place yourself out of your comfort zone. After the initial transition period, most people will get adjusted to the new system and workflows and overcome these issues. And last but not the least, ask for help. Realize that you are not alone in this. There are some general QPP related strategies that will guide and help you for the successful participation. These include proper planning, know where to find resources regarding measures, reporting, and various submission mechanisms and deadlines. Having a valid HARP account, HICCUS access roles and profile, is also essential for logging into the QPP portal. My colleague will post a link on information on HARP account in the chat box in a moment. And if you are still feeling that you are muddling through QPP, we are here to help. Visit our website for more information. Self-care is how you take your power back. Meditation, exercise, vacations, and finding time for self-care will help you to regain sanity and peace of mind. And try to develop a support system, including colleagues, family, and friends. Always leave all work-related troubles at the hospital and try to relax or rest once you are back home. I have included a link with some great resources from Stanford Medical Group. They have 24/7 hotline for clinicians, counseling services, and various resources geared towards physician well-being. And please find links for various resources used throughout this presentation. Now we are open for questions and discussion. Press #6 to unmute yourself to ask questions over the phone. Press *6 to unmute yourself to ask questions over the phone. Or please type in questions in the chat. We will try our best to answer all your questions. We want to assure that even if we couldn't answer any of your questions immediately, we will definitely get back to you with answers as soon as possible. Or if you think you need more time and have multiple questions, feel free to email or call us. Our contact information is displayed on the next slide.
Can I ask the question?
Sure.
This is Dr. Patel. I like the presentation. I agree our goal should be better care and low cost. We all are depending on EMR company and vendors. What is being done to regulate them to support us correctly, and they should be doing things in a cost-effective fashion? What we found lately is we get 2 or 3 or 4% more, but we spend 10% more to recover that money, and our staff get frustrated. And this is a burnout issue, but I'm just asking, what is the regulation doing, or who is doing the regulation?
So thank you. That's a great question. So I totally understand you. It's so stressful. So we are not aware of any current CMS regulations on the EHR vendors, but we can definitely do some research on that, and I will get back to you as soon as possible. In the meantime, I hope you found the presentation helpful, especially the strategies to overcome stress related to the PI category that is very much related to the EHR. So for this program, unfortunately, you need to have like an EHR system to participate successfully in the PI category. So you need to have that, but I can definitely do some research on any regulations if there are any, and I will get back to you as soon as possible. And thank you for asking that question.
Is this presentation is on a video recorded I saw? Can we, or our staff can look it up online?
Yes, it's currently being recorded, and as soon as the recording is available, which should hopefully be in the next few business days, I'll post it to the same event page where you can download the slides. A link to that event page will be in the follow-up email.
Wonderful, thank you.
While we wait for a few more questions to come in, either on chat or over the phone, we're going to post the evaluation link into the chat. If you don't have time to fill out the evaluation right now, or if you're currently sharing a computer with someone else, you'll receive an email tomorrow with a link to the evaluation. We do appreciate your feedback. And please connect with us on social media for our latest resources, webinars, and other offerings. Links to our social media pages will be included in tomorrow's email. In the next few business days, the caption recording of the webinar will be posted to the event page. Please check back if you're interested in viewing or sharing the recording.
So we have a question in the chat. I will read that alone. Thank you, Steve. Thank you so much for your question. Your strategies are excellent for achieving success with QPP, but all add administrative burden for physicians who need to concentrate on patient care issues. Hiring help with this and related workload adds costs greater than added reimbursement will add. This creates the discouragement that causes burnout. How can the QPP program be simplified to relieve burden and burnout from that side? So the program is created by CMS, and CMS is realizing that the program is causing so much burnout to the physicians. So CMS is trying hard to simplify the program. So it's mostly not by reducing the reported requirements, but by providing more help, resources, and guidance to the clinicians. So our organization is a CMS contractor, and we provide QPP technical assistance to all physicians and eligible clinicians in New England region. So there are so many other contractors like us who provides the same help and technical assistance and make sure that the eligible clinicians and practices are successful in reporting. So what you can do, or even physicians and practices can do, is to contact us. We help them with choosing the right measures, help them to report successfully, help them with their workflows, and provide all support they need to successfully participate in the program. Unfortunately, I don't know, like CMS is planning to take this program off or reduce the reporting requirements. I guess it will just increase the reporting requirements, but you can expect more help, technical assistance, and support through resources. And the positive payment adjustment will increase year after year, as well as the penalties for non-participation. Hope that helps. So thank you for that comment. I'll read that aloud. Thank you, but I'm skeptical that it will be enough for small practices to succeed. Larger ones can benefit from scale to spread the cost over a greater denominator. I totally understand that, and it's true too, but under this program, small practices are getting a lot of flexibility. For example, they can apply for the PI hardship exception so that they don't have to report for the PI category. That is the biggest burnout for many small clinicians and solo practices. And besides, even within our organization, we have like a specific group that helps the small practices and solo clinicians to successfully report for this program. And all of our services are 100% free of cost. It's no cost or anything associated with it. So there are so many other organizations that does the same thing. So we always help them, and we are always willing to help them one-on-one by providing them support. We do site visits. We help them choose the right measures, make sure that the data submission is complete and appropriate. And again, another thing is like the small practices can always report as groups so that the burden will be alleviated. They will receive like a group score. They'll be reporting on the same measures and receive like a group score and payment adjustments. So CMS is trying hard to provide maximum flexibility and support to the small practices and those in the rural and underserved areas. Hope that answers your question and comment. So please feel free to reach out to us, either Susan or myself, if you have any questions. As I mentioned earlier, we provide technical assistance at totally free of cost. We are happy to help you. We will sit down with you, choose the right quality measures and other category measures and ensure successful data reporting and submission.
All right, it's noon. My apologies, it's noon now, so we're going to close out the webinar. Thanks everyone so much for attending. Again, the evaluation link is posted in chat. Feel free to fill that out, or you'll get a follow-up email where you can fill it out from there as well. Have a great day.
Thank you.